Surgery will move on to lenticule-based refractive procedure. Refractive lenticule extraction is becoming the procedure of choice due to its high precision and biomechanical stability. Let me call upon Dr. Rohit Georgie Matthew. He is the head of cornea and refractive services at Lotus Eye Hospital, Kochi.
Good morning, all. Thank you, Dr. Kala, for the opportunity given. So, as mentioned, already the well-known surgeries are LASIK and PRKs. I'm not against any older techniques because it's all an innovation which is happening. So, the latest generation is called the CLEX, the keratolendicular extraction surgery. I'll be talking about the SMILE. So, no financial interest on any machines. So it's a minimally invasive laser correction with keratolendicular extraction, which has been done with femto. And the advantage over the older procedure is there is no flap. It's a single procedure. Only one machine need to be used, and only completely it will be femto lasers used. And intrastromal keratomyelitis is being reinvented as refractive lenticular extraction. So these are the four new generation femto lasers for the lenticular extraction surgeries. This is first one is Visumax 500, which has been launched 10 years back, and 800 is the current one. And the Femto LBD by Z8 by Zimmer is there, and Elita by J&J, where Dr. Kala will be talking, and Atos by Schwind. So basically all the treatments are being done on the pupillary and visual axis, and the pulse duration frequency is from 500 kilohertz to 20 megahertz. It depends upon the machine, and the energy per pulse is 10 nanojoules to 150 nanojoules. The laser spot size is 0.5 to 1 micron, and 3D displacements is 2 to 5 microns. It's all a spiral laser delivery which has been delivered. So the mechanism is the ultra short laser power pulse at very high speed. It bonds between cell broken by photo disruption, and micro gas bubbles create tissue cleavages, which helps in precise tissue transaction at the focus plane within the cornea. So the dimensions are, what I take is usually optic zone of 6 to 6.5, cap diameter is 0.5 to 1 over the optic zone, and the cap thickness is 110 to 120 microns. Side cuts is 2 to 5 millimeter, placed at 90 to 180 incision, and the refractive correction determines the shape and the size of the lenticule. So this is a cross section where you can see the first one is a lenticular cut which will be done, second is a vertical cut, third is the cap, and the last will be the side cut to remove the lenticule. So procedure is basically the data entry onto the machine, and topical anesthesia, eye washes and eyelid cleaning, and curved conical contact lens is being used as a medium, and the eye is brought to the contact lens, and the patient aligned at specific light. The patient will be asked to look onto a green color light, and the suction is activated, and the laser is delivered. So the time duration of the laser depends upon the machine. The size 800 is having around 5 seconds it will be delivered. The procedure continues the side cut is open, the lenticular separated from the anterior stroma, and then the posterior stroma, and the lenticule is removed. Post-operative, give antibiotic and steroid combination for a week, and artificial tears and protective glasses. The intensity and the duration of the medicines can be reduced by these type of lenticular based surgeries, whereas in LASIK I usually give a little more longer. So the CLEX benefit is basically it's a convex shaped lenticule, subbasal nerve plexus relatively spared, and the subepithelial plexus are also spared. The stromal innervation dents at the periphery are not affected. The corneal sensation is much better than LASIK, and the electronic dry eye is very less. So this is a video where the patient is brought to the machine. There will be a cone which will be the interface, and once the suction is activated, the laser is started. So you can see the flap cut, vertical cuts, and last the side cut. Once the patient is brought to the microscope, the side cut is open, separating the posterior and the anterior lenticule. And after separating it, the lenticule has been either rolled out or pulled out. So this is a study which was conducted in, published in 2014 JCRS, where the 3 months results showing the SMILE is having a much better refractive accuracy, dry eye and less dry eye and better contrast, and induced aberrations are lesser. And the contraindications are mainly already spoken by Dr. Nanakuti sir. Corneal ectasia condition, corneal scars, presbyopia, and pachymetry less than 480 microns, and residual not less than 260, and small papillary fissures, and anxious and uncooperative patients were unable to do it. So the main complications which happen from SMILE is suction loss. Redocking after suction loss is a task, and flap tear can happen while during the lenticular extraction, and lenticular irregular dissection is another complication which happens when you have a thinner lenticule, and it's a learning curve, because most of the cataract surgeons will be able to do a lenticular extraction surgery. So I conclude, there's no flap, the anterior stroma is not weakened, very high powers up to 10 diopters of sphere, and minus 5 cylinder power can be corrected. Even hyperopic correction also can be done, and less higher order aberration, minimally invasive, and it's a general procedure, and all in a single step, and the biomechanics are less affected, and iatronic dry eye is less, and the wow factor, it's like the day one you'll get 6/6 vision. Thank you.